Welcome to Week 7. We've covered observational designs, cohort and case control studies. Today we reach the top of the evidence hierarchy, the randomized controlled trial, or RCT. The RCT is considered the gold standard for establishing causation because it controls for confounding through randomization. When properly conducted, RCTs can tell us whether interventions truly work. For healthcare managers, understanding RCTs is essential. Clinical practice guidelines rely heavily on RCT evidence. Drug and device approvals require RCT data. Quality improvement increasingly incorporates randomized designs. You need to critically evaluate this evidence. Let me explain the core principles that make RCTs powerful. Random allocation means participants have equal, or known, probability of receiving intervention or control, determined by chance. This is the magic that distinguishes RCTs from observational studies. A concurrent comparison group receives either placebo, standard care, or an alternative intervention. Both groups are followed simultaneously under the same conditions. Prospective follow-up means outcomes are measured after randomization. You're looking forward, not backward. Intent-to-treat analysis includes all randomized participants in their assigned groups, regardless of whether they actually received the intervention. This preserves the benefits of randomization. Blinding prevents knowledge of assignment from influencing outcomes or their measurement. Single-blind means participants don't know their assignment. Double-blind means neither participants nor outcome assessors know. Triple-blind extends to analysts. Randomization is the key feature that elevates RCTs above observational designs. Let me explain why it matters so much. In observational studies, people who receive an intervention differ systematically from those who don't. People who take statins may be more health conscious, have better healthcare access, and differ in countless ways from non-users. These differences confound the association between statins and outcomes. Randomization breaks this link. Assignment is determined by chance, not by patient characteristics, physician preferences, or anything else. The intervention group and control group differ only by random variation. With large enough samples, randomization balances all characteristics, measured and unmeasured, between groups. Age, sex, disease severity, genetics, lifestyle factors, things we don't even know to measure, all balanced by chance. This means any difference in outcomes between groups can be attributed to the intervention itself, not to baseline differences. That's causal inference. No observational design, no matter how carefully done, can fully eliminate confounding by unmeasured factors. Randomization can. That's why RCTs sit atop the evidence hierarchy. RCTs come in several variations designed for different situations. Parallel group trials are the classic design. Participants are randomized to intervention or control and followed separately. Most drug trials use this design. Crossover trials have each participant receive both intervention and control in sequence, with a washout period between. Each person serves as their own control. This is efficient but only works for conditions where treatment effects are reversible. Cluster randomized trials randomize groups, hospitals, clinics, communities, rather than individuals. This is necessary when the intervention operates at the group level, like a hospital-wide quality improvement program. Analysis must account for clustering. Factorial designs test multiple interventions simultaneously. A 2x2 factorial tests intervention A, intervention B, both, or neither. Efficient for testing combinations but complex to interpret. Non-inferiority trials test whether a new treatment is not worse than standard treatment by more than a specified margin. Equivalence trials test whether two treatments are essentially the same. These are common for generic drugs and devices. Conducting a rigorous RCT requires attention to several key elements. Sample size calculations determine how many participants are needed to detect a clinically meaningful difference with adequate statistical power. Underpowered trials waste resources and may miss real effects. Randomization procedures must prevent anyone from predicting or influencing assignments. Allocation concealment, keeping upcoming assignments secret until enrollment, prevents selection bias. Central randomization systems or sealed envelopes are common approaches. Blinding prevents expectations from influencing outcomes. Placebos that look identical to active treatment enable participant blinding. Outcome assessors should be blinded when outcomes involve judgment. Outcome measurement should be objective when possible. Mortality is unambiguous. Patient-reported outcomes are susceptible to bias. Validated instruments improve reliability. The analysis plan should be pre-specified and ideally registered before unblinding. This prevents selective reporting of favorable results and data-driven analysis choices. RCTs have important limitations despite their strengths. Cost and time are substantial. Large RCTs cost millions and take years. Not every question justifies this investment. Ethical constraints limit what can be studied. We cannot randomize people to smoke or to receive no treatment for serious illness. Equipoise, genuine uncertainty about which treatment is better, is required. Eligibility criteria often exclude patients who might receive the treatment in practice, the elderly, those with comorbidities, pregnant women. Trial populations may not represent real-world patients. The efficacy-effectiveness gap matters. RCTs show efficacy under ideal conditions with careful follow-up. Effectiveness in routine practice may be lower due to adherence issues and less intensive management. Some questions can't be answered by RCTs, rare outcomes need impossibly large samples. Long-term effects require impractical follow-up. Many public health interventions can't be randomly assigned. For healthcare managers, this means RCT evidence is valuable but not sufficient. You also need observational data on effectiveness, safety surveillance, and implementation research. Canada has contributed significantly to RCT evidence. Let me highlight some examples. The CANPAP trial tested continuous positive airway pressure for patients with sleep apnea and heart failure. Conducted across Canadian centres, it showed no benefit for the primary outcome but informed understanding of this common comorbidity. The DREAM trial tested whether ramipril or rosiglitazone could prevent diabetes in high-risk individuals. Canadian-led, it demonstrated that rosiglitazone reduced diabetes incidence but raised concerns about cardiovascular safety. Canadian centres participated in major international trials like ACCORD, testing intensive glucose control in type 2 diabetes, with important findings about risks of hypoglycemia. During COVID-19, Canada participated in recovery and solidarity trials that identified effective treatments like dexamethasone and showed ineffective treatments like hydroxychloroquine. Canadian Cardiovascular Society guidelines are informed by trials conducted at Canadian centres, directly influencing practice standards. As healthcare managers, you implement findings from these trials. Understanding their design and limitations helps you apply them appropriately. Let's summarize randomized controlled trials. Randomization is what makes RCTs special. By allocating treatment by chance, randomization balances all confounders, measured and unmeasured, between groups. This allows causal inference. RCTs provide the strongest evidence for whether interventions work. They sit atop evidence hierarchies and form the foundation of clinical guidelines and regulatory approval. Blinding and allocation concealment reduce the risk of bias from expectations and selection. These methodological features distinguish rigorous from poor-quality trials. Limitations include cost, ethical constraints on randomization, restricted eligibility criteria, and the efficacy-effectiveness gap. RCTs answer specific questions under specific conditions. For healthcare managers, RCT evidence informs guidelines, formulary decisions, and program development. Critical appraisal skills help you apply this evidence appropriately. Next week, we tackle bias and confounding in depth, the threats to validity that plague all study designs. Assignment: find the RCT evidence behind a clinical guideline relevant to your practice area. What was the study population? How generalizable are the results to your patients? See you next week.